All right, good morning, everybody. Thank you so much for joining us for today's talk. My name is Stephanie, and I will be monitoring things out here, hoping that everything goes well with the technology. Always on. If you parked in the parking deck and you have a little ticket, please make sure that you see the front desk people so you can get a validation pass, and that will validate your parking so you don't have to pay when you leave. So when you leave, you'll just scan the ticket, scan the validation pass, and we will be all set. We have a couple of events coming up in September. We have Dr. Sonia Scholes from NIH coming to Ann Arbor. I'm going to be doing a talk in Ann Arbor this year. It will be at the Kensington Hotel, and she's going to be talking on Lewy body dementia in focus, lives, lessons, and hope. So that should be a good talk. I have a flyer right there for that. And then our October speaker series will be virtually. Dr. Vikas Kotikal will be speaking on Lewy body dementia, particularly falls and different types of Lewy body dementias. So hopefully you can make that as well. That one is virtual, and I have that flyer right here. You can register with the little QR code. And without further ado, I would like to bring up our speaker for today, Dr. Bruno Giordani. Yay!
Parking is outside validated, not inside.
Oh,
yeah. If you remember to go to that office out there. So.
Yep. I'll make sure everybody gets their parking stuff. Would you like the clicker?
Yep.
I think it's. Make sure it's all clicked.
Whoop.
There you go.
Okay, thank you.
Hi.
Hi, folks. So this is always, I hate to do this to you all, but I always apologize because this talk comes right after Alzheimer's International Conference and my family's vacation in Nova Scotia, so that I never quite know what's happening by the time I get back. So you guys are a guinea pig to see if I have enough slides or don't have enough slides. I can always add some more at the end that we can work out, but usually I talk too much anyway. So this is the Alzheimer's International Conference, which was in Toronto this year. It's every year. Centuries ago, it used to be every other year, but there's so many things going on in Alzheimer's research. It's every year. And I went, as Stephanie knows, somebody who works with us is very big on Indian food. And you've got to stay away from these places because the spice level is just beyond belief. And I think he enjoyed taking me to these places. But we're going to talk a little bit about Alzheimer's disease, talk about some definitions, some new medications that are out there, and just sort of see what some of the other general research was like at AAIC. So this is an annual event. It's kind of neat because it brings all sorts of people together in one meeting. Usually in a medical meeting, you have a whole bunch of neurologists or a whole bunch of psychologists or a whole bunch of internal medicine people. But what AAIC does every year is it brings people across all the disciplines to talk together. So you get around 10,000 people wandering around this giant venue and on the internet things. And it's quite a neat event. So let's talk terminology first. The reason why terminology makes a difference is terminology makes a difference in terms of just understanding the disease process, which we now know pretty much what happens, but it also fits very interestingly with interventions and things and medications and things. So dementia, I can go over these pretty quickly because I do this every year. I try and change the slide just so it doesn't quite look as boring, but we always have this discussion, what's dementia, what's Alzheimer's. Alzheimer's is the highest percentage, around 60–70% of patients have Alzheimer's, but they may have mixed pathology too. So there's multiple things going on, but there are all those different types, vascular dementia, Lewy body disease, which we just heard about, will be another talk, frontal temporal dementia. All of these are dementias, which means basically a cognitive change that affects your life, for which you can't carry on your life as you normally used to. This comes from Dr. Alzheimer's. There he is himself right there, who met this lady, Auguste Dieter, when she was 51 years old. He noticed that she did not look like all the other patients in the psychiatric facility where he met her. She had memory loss, language problems. She would start to write her name, would forget what she was writing. It clearly didn't look like other patients in a psychiatric hospital. And so he followed her. And when she died, he looked at her brain. And because, you know, if you were a psychiatrist back then, you were also a neurologist, a neurosurgeon, a pathologist, and everything. So he asked them to save her brain. There was somebody else doing very similar work at the same time. But then he looked, and that was an original, that's sort of a picture of the original slide. But he drew what he saw. And if you notice, these things look very much like these things. These are neurofibrillary tangles. These are amyloid plaques. These are the classic, and we'll talk a little bit more about that, but these are the classic signs of Alzheimer's disease. So we know that it has specific symptoms: memory loss, confusion, difficulty orientation. We will plaques and tangles. We'll talk about in a minute. The risk factors, there are ones you can control, but we can't control this one, unfortunately. And genetics is pretty hard to control. But there are other things we now know are controllable and do relate to risk. All these different things are risk factors, and they demonstrate that every year when at this meeting, Lancet, which is a big journal in Europe, Lancet comes out with a review of risk factors. And it lists the basic, and we'll take a little picture of, I'll show you a little picture of what they do every year in a little bit, but they list a whole set of risk factors, things that heighten our risk for this problem. And it's interesting because they're very touchy right now, because you'll notice that a glaring omission some people feel here is sleep. And so the head of the Lancet Commission got up and basically said, I'm tired of everybody saying sleep, but we can't find results that demonstrate sleep as a real risk factor, although many people know quite well it is, especially if you have sleep apnea and sleep problems. But the difficulty is there's so many different problems with sleep, so it doesn't make the grade. So she gets yelled at a lot, she said. But so every 3 seconds, there's a new case. 60-80% of all dementias, 1 in 9 individuals over 65 have this disease. 55 million people currently living with Alzheimer's or other types of dementia. This is going to jump like crazy by 2050. It's the leading cause of death among older individuals, has a massive cost. And the other issue is 75% of people with dementia are not diagnosed. This is Alzheimer's disease and all those other things. They live without a clear diagnosis. So these things become a real issue, and it's a global issue. I spend a good portion of my time, now that COVID's over with again, in Africa, and those numbers are really hard to generate in Africa, because until now we really haven't had good triage and things, and also because, for example, HIV was killing people so early, and now with good HIV antiretrovirals, combined drugs, people live long lives, and suddenly it's appearing as a significant issue. But you can see Asia really faces, China, those areas really face significant problems because age is the biggest risk factor. All those risk factors I showed you, those are things we can do something about. We can't do something about age. And that's the real clinker in all this. The other thing I want to just mention is that we have, you know, I'm going to use this because otherwise I'm going to fall over. If you see me after September 5th, well, if you see me a month after September 15th, I'll be walking great. But if you see me from September 15th for that month, I'll probably be in a lot of pain, but hopefully not with this knee. But anyway, we know that as we age, we generally, our skills, we now know really don't decline. There's a little bit of a decline in some basic things like attention and things and focus and things. But really, as we age, the biggest issues that start to occur are mild cognitive impairment, we'll talk about, and then dementia, which goes down. But there's this whole piece in here, this sort of what they call preclinical piece, and then prodromal piece, the pieces that come before that are the issue. Can we intervene early on in this disease and slow it down? But I want to mention mild cognitive impairment because you will see this diagnosis much more now. It's kind of that middle path here where the cognitive changes, remember I said dementia is when cognitive problems and changes get beyond your control in terms of daily life. Mild cognitive impairment is basically an obvious change in cognition or a noticeable change in cognition that still doesn't affect your daily life. But mild cognitive impairment is sort of a transitional diagnosis. Alzheimer's disease is not a switch you turn on and off. It's a gradual change. We know why it is, and it's not like normal aging at all, but it's that gradual change. And we know that 1 in 3 people who have MCI will go on to develop Alzheimer's disease. So that's a big issue. And we know a significant chunk of people over age 60 actually have mild cognitive impairment. So that's why new medications, new approaches and things are really important. So the other thing we know about all this is that this is a disorder that changes the brain. There's no coming back in many aspects from this disease once it affects you. So once these changes occur in the brain, cells begin to die, and it's a significant effect on the brain. Well, we're going to talk. But there are different things to avoid this disease you can do, or at least to reduce your risk, right? Did you ask me a question? I don't know if you want to talk to each other. Yeah, okay. So all those different risk factors I showed, that at least if you can get a handle on those things, especially the medical ones, we know that cardiovascular disease, diabetes, all of these things, when not controlled, become a risk. Smoking is a risk. A number of the lifetime things are risks. If we can reduce those risks, we can do something significant. And when we were looking at those that risk factors before, you know, these are things that can be changed. Hearing loss turns out to be a big issue. You know, you'd be really surprised, but hearing loss, even more than genetics, is a predictor of dementia. So hearing loss became really a big factor. They've done a very big study that says, what if we take older individuals and improve their hearing before they have significant changes? And actually, that study did not show significant effects. But in individuals who already had mild problems, that was a big change. So there are a lot of things we do at different times, but these are the things why it's really important to talk to your clinician, your physician, about what should I do and what can't I do. Walking is a big issue. That's a big improvement too.
Excuse me, sir.
Can
you, because I wear hearing aids, so I was wondering, what was the difference that you were talking about, or study versus,
It looks like, this was a study that came out last year. It looks like people who have uncorrected hearing, who don't have hearing, who are older and already have started having cognitive problems, they are very much affected. Whereas individuals in the general population who we find have hearing problems, there's not as much of a risk reduction in that group. And it's interesting because there's still an improvement, because if people can't hear, they don't go out, they don't do a lot of those other things here, right? I mean, my father had significant hearing problems. It was hard to get him out of the house because he loved to go to talks and loved to go to museums and things, but when he couldn't hear, he wouldn't do those. So that sort of leads to other problems. That's why it's important to try to affect these risk problems. And I can't do anything. It turns out there are some things now they're developing that might affect your genetics, but I can't affect your age. I can't affect your family history. We know there's some relationship there, but cardiovascular disease and any of those other things we can't affect ourselves. And, I have people come up to me all the time and say, my father was, ran 15 miles a day, and why did he get home? I mean, I can't tell you that, but we do know they are important features. So the cost of Alzheimer's disease, I'll just bring up because we need to consider what this means for all of us. The costs are more than cancer and heart disease. Caring for individuals with Alzheimer's disease has a massive cost because it usually falls to a partner, someone to help that individual in their home as they develop cognitive problems and have more difficulties, or as they go into senior living facilities and things. So it's a lot of cost. It's also a very big cost for Medicare, and it's only going to get even larger. So it's a significant strain on the environment. Every year, the Alzheimer's Association at this meeting puts out a facts and figures panel of sort of what are the latest facts and figures. And we've seen some changes in this, which is interesting. Now, one of the biggest changes we saw, for example, is that actually overall the number of individuals who have this disease is slowing a little bit in Western countries, especially. And why? Because of diet changes and all these other pieces are having an effect. I spend a lot of time in a couple of different African countries, and the big thing is to eat fried food like they do in the US. Kentucky Fried Chicken are opening up and all these other places, and it's killing not killing, but you don't get the same vegetables like you used to, the same, unless you go to a traditional place to eat, which is nice because I do. But at least I don't tell my wife I go to KFC, it's in Uganda. But 1 in 3 older adults dies. We've already seen this. Deaths from heart disease have gone down, whereas deaths in Alzheimer's have gone up. So why do you think the sudden giant change in death?
Longer life.
Yep. Longer life and age is the biggest predictor. We're staying longer, we're staying healthier, we're doing more things, people live older, and yet age, you get to be about 85, you're running a much higher risk of dementia. That's why you may hear somebody talk about super aging study going on that's also at University of Michigan, looking for individuals in their 80s who are doing well. But again, the other big issues, the number of people across the US who are providing care, the cost of that care because that person isn't working anymore. So it's a significant issue. So risk goes up. In Michigan, there were new facts and figures published here. I don't know if Michigan does an infographic. I don't know if it's out yet, but there's a lot of interest now in Michigan about this, which is really nice to see. We used to have a dementia group within the aging group, and that sort of went away due to political interests and things like that. And because of a grant the Alzheimer's Association got, that group is actually sort of reforming itself, and the Dementia Coalition in the state is going much, is much more regular, much faster. So that's really an important thing, and the new co-director of that is at Wayne State. So again, these issues become increasingly a part of the state because of the change in death rates, the number of people living at home, the number of people then going to nursing homes and things like that, whereas trying to keep people at home is really critically important. And how do you do that? It's really hard. You need support in the home. My son has a company that does computer setups for people in their homes and things like that, so that they can live more independently. These things are really critically important.
Sir, why is it that women have an increased risk? It said 1 in 5 for women compared to men.
Well, I think I talk about that in. I'm sorry. Oh, geez, I'm not supposed to do that always. Stephanie's really nice. She doesn't sit in the back and scream at me when I don't do something. But the question was, why do women have a higher risk? And there's, yeah. And at first, everybody said, oh, women live long. But that's not true. When you adjust for age and look at those other things, there are many things associated. Men and women don't have the same brains. There are differences in the way brains are structured a little bit. So that we know that men may have an earlier onset. There may be differences in these types of proteins we'll talk about in a second in different brains. These things seem to affect women more. Risk factors for women seem to be highlighted more than men in certain areas. So we'll talk about that. If I get it, but we'll see. So
I thought we have plenty of time.
Okay, good. And I really cut down the slides because I talk so long, Stephanie gets mad at me. So I'm trying to keep Stephanie from getting mad, but I may have cut out too many. But our brains are made up of billions of these guys. These are neurons. They sit up there in the electrical connectivity in the brain, and every neuron cell has an axon, and axons send dendritic, they call them messenger, to other cells. So if I want to move my hand up and down, all these different cells are lighting up in my brain saying the crazy guy wants to flap his hand. So flap your hand. But these are the ways that our body communicates with the brain through these cells. And we know there are billions of neurons and gazillions of these synapses. But to stay healthy, the brain has to keep these going. I mean, think about, because we found out, think about Michigan, trying to drive through Michigan highways. There's blockages, there's orange cones, there's all this other stuff going on. That's what happens when you're trying to send clear messages from one side to another. Now, we've known what happens here for a good while. We just haven't been able to do anything about it, and that's what we'll talk about, the changes now. But our brain has things called APP, precursor proteins. These are the things that the brain lives on. These proteins, and proteins get digested by neurons, by brain cells, and things like that. It's like going to McDonald's. The problem is, if the wrong chef is at McDonald's and doesn't cut the food right, you get into problems. So in the brain, there are things called nucleotides. I mean, excuse me, sorry, called these protons, these secretases come along and cut these cells in the right way. Alpha secretase is the chef. You know, whether you guys watch the programs on, I don't have time to watch sometimes, but the cooking shows, you know, and there's the chef who's in charge of everything. That's what alpha secretase is. But the problem is there are not such smart chefs that are beta secretase and gamma secretase, that when they come along and cut up those proteins, they don't cut them up properly. So what happens is you get these precursor proteins kind of sticking together because they're really sticky and forming clumps or oligomers, clumps of protein of A beta of amyloid. It sticks together and it begins to make a mess in the brain because they're sticky, and these proteins can't be digested. They sit in the way, and we know that they turn into these clumps of proteins called plaques that start to cause all sorts of things, all sorts of stresses in the brain. It's sort of like if you get a cut, you know, cells start going crazy, you get inflammation, you get oxidation, and as this stuff all occurs, axons begin to fall apart. So those messenger parts of the cell that we looked at a minute ago begin to fall apart because they're full of tau, which holds them together. And when that starts to fall out, they fall out. And the tau actually re-enters, essentially and simplistically re-enters the cell, and cells begin to die. So what you get is, right slide. Rather than this nice, healthy system, of course, it's much more clumped together, but this nice, healthy system of cells, you get plaque, and you get these tangles, these misshapen cells. And these misshapen cells eventually die. So we know this. It's a nice, simple, I mean, not simple, but it's a process that occurs that we've known about for a while. The problem is we don't treat people till they have dementia, or at least normally used to be. Because we treated people when they got a diagnosis of Alzheimer's disease, and then we use different medications, like if people here have heard of Aricept or, you know, all these different medications, which are for symptoms of the disease, but don't do anything for the disease, right? These are medications that don't affect the disease process itself. They only help at the very end by increasing the chemicals in the brain that do the messaging. So what they do is they improve the ability of these cells to communicate with each other, but they don't do anything to help these cells, to stop them from forming, to stop that whole process. And we also know we now know that this is like a 20-year process. We know that people first start seeing the beginnings of plaques and tangles 20 years before they have memory. And that's that key. If this process here takes 20 years before you see symptoms, that's a time when we're not doing anything when we ought to be doing something. We can slow this process for people feel by doing some of those, lowering those risk factors, but this process marches on too. So it's, you know, you have to wonder, why can't you do anything in here? And the answer is people have been doing this research now for, you know, the other thing you have to realize is nobody really knew about this disorder and what it looked like until Dr. Alzheimer's looked in somebody's brain. And then the problem was August Dieter, whose brain he looked at and said, whoa, this is not a normal aging brain. that after this lady died. The problem was she was 51 years old. She had early onset Alzheimer's, which we know follows basically the same process as Alzheimer's. But then everybody started talking about early, when I was young, like 12 or 13 working in this field, people, we studied very young people who were developing dementia. We didn't look at older individuals. Everybody used to say, oh, as you get older, you have problems. There's nothing we can do about it. Nobody really made that connection for it till the 70s and 80s. So it sort of went from 1900s till then without a clear process of identifying the disease. So now that we can identify it, we can begin to say, wait a minute, we know what happens. How can we interfere in this early area in here? How can we stop amyloid from forming? Or how can we get rid of these plaques? Or how can we stop tau from falling out of these axons and falling apart? But until the past couple years, there's been no way to do that. There's been a lot of money spent on this. A couple of large pharmaceutical firms have stopped even doing this research because they spent so much money on it. And one of the problems, probably why, was because those medications were studied in very ill people with severe dementias or moderate dementias, not at a time when it would make a difference. Because if you try and treat somebody way down here, after this has all gone on, it's not a very effective treatment, right? Because all this stuff has already occurred. So that's why all of these things become really important. We know a lot of this because of something called ADNI, the Alzheimer's Disease Neuroimaging Initiative, which actually was a nice time because science cooperated with the government, cooperated with the Alzheimer's Association, and everybody got together. Am I in here when? No, okay. Everybody got together and got something done, which was to take all of these different sites, a number of different sites around the country who were doing PET scans. We'll talk about that in a second, doing other types of things and saying, I want you to do it the same way. Because everybody, you wouldn't think about it, but every MRI machine is managed in a different way. If you're high on a mountain versus low in a valley, your MRI or your CT scan is actually different, unless they're all coded the same way. And because these changes are very small that we're looking at, you need to have all these systems work. And so all of this interest in MRI, in PET scans, in DTI, which looks at how different parts of the brain communicates, genetics, CSF, spinal fluid, cognitive testing, all of this stuff got centered together in ADNI. And now ADNI is very interested in that stuff up there, which is blood. Talk about. Suddenly, blood is a very interesting thing because it costs quite a bit of money to get a PET scan. It costs me $3,500 just to do an amyloid scan.
Yeah, like you're doing how?
Yeah, it's like double. So I can't even do that for research anymore. I can't afford to do that. And yet there are requirements still in terms of medication, things we'll talk about. But basically, this system worked very well to show us what was going on. And what this system showed us is that there is a framework for Alzheimer's. I call it Alzheimer's Association framework. You can say Clifford Jack, you can say Rhesus Frohlich. Lots of people were involved in it. But it's a way of defining Alzheimer's disease. And we define it biologically. That is what this program does. This framework says is we can look at plaque in the brain. We can look at this is the earliest indicator, plaque. We can then look at tau in the brain. We can now image tau, which hasn't been except the past couple of years. And then tau tells us, I'll talk to you about what tau tells us, but how then we follow neurological disease, essentially dying parts of the brain, which show us by PET scan. So for example, amyloid, the first thing that comes along is a risk factor. And I'll show you some pictures that say why. But amyloid is our risk factor. Tau follows the beginnings of the disease and the disease process. But as cells begin to die, we see that on MRI scans and on PET scans, glucose PET scans. This is a scan of a normal individual. This is somebody who has Alzheimer's disease, and you see a characteristic pattern here of less activity. Now, when I was much younger, this is all we had. We didn't even have that stuff. That stuff is fairly recent. This is what we used to do, and we used to be great at diagnosing Alzheimer's disease, but it was far too late. We're trying to make sure brains stay like this. So this is the issue that goes along. This is the pattern of what happens, and we know this because of all these studies. This is a little bit out of date, but this fellow Clifford Jack comes every year and has a different slide to show for what happens in Alzheimer's disease. But it's true, this is what happens. We know that in a pre-symptomatic stage, before somebody has obvious symptoms, amyloid is depositing like crazy in the brain. So this is a risk factor, whether it's done from PET scan or CSF, this is our risk factor. This tells you the risk. And then as these other things begin to appear, as tau begins to appear in the brain, tau becomes the monitor of actual what's going on in the process. So if you had a line here that defined Alzheimer's disease, it really wouldn't be until all these different markers hit it, because people have to begin to have cognitive impairment and other things. But if you see amyloid, it's already reached the top. So if you were taking people here that had obvious dementia, taking amyloid out of the brain is not doing you much good, right? So a lot of these early studies that removed amyloid in the brain from people with dementia, that's why they may not have worked. Because all the damage had already been done, had already been started by amyloid in the brain. Does that make sense to everybody? You get that kind of idea? I mean, it's amyloid is the thing that goes, oh my gosh, there's something funky going on. But until tau gets involved, that's what happens. You don't get this effect. Many people have amyloid, there's about 20% of people in this world are wandering around with a brain full of amyloid. They will pass away with that brain full of amyloid. They will never have had problems. Now, that's a very interesting group of people, because how come? That becomes a really interesting group of people to study. People are looking at that. But we know now, amyloid gets deposited, those clumpy cells, they begin to make a mess in the brain. And about 15, 20 years later, you begin to see tau appearing, and then you get to see these symptoms. Now, there's all sorts of arguments, because some people say, well, tau has always been there. I agree, but not falling out of blood vessels, not falling out of cells, not leading to death of cells. So I started this way, Clifford Jack. You guys don't know Clifford Jack. He's a very nice guy, but every year he comes with a different slide. And people are getting kind of tired of his lines and all this stuff. And oh my God, here we go again. But the other thing that over the past 2 years has been an undercurrent of issues is this very diagnostic piece. And this is what I want to mention, because it affects how we treat the disease. It affects how we think about the disease. What his working group, Risa Sperling and others, said is it is necessary to separate clinical symptoms or cognitive problems from the biology of the disease. If you truly want to diagnose this disease, you diagnose it by the biology, because people's symptoms can look very different. So if we look at what's happening in the brain, we can diagnose it, and that means we could diagnose people before they have problems, right? Very interesting piece. So what they say is we have a framework where we have an initial biological stage, which is really nothing much going on, but amyloid is being deposited. Then we have a biological stage where tau begins to appear, and then brain cells begin to die, and this matches a clinical stage. This would be what Alzheimer's looks like, but we know it doesn't always fall in a nice pattern. It's not that easy to diagnose because sometimes you have people who have very little clinical problems, but a lot of biology. You know, we don't know why. This is an important thing to understand. We know that other people have a lot of symptoms and a lot of biology. That's pretty clear. But all of this work is leading to the fact that how can you best define the disease and how can you best treat the disease? So what the biologists, what the MRI folks, what the PET scan folks in the group are saying, let me diagnose this early to see what's happening, amyloid deposits in the brain, and then we can affect what's going on. We could intervene early, and we'll look at what's happening. Now, another thing we know is people who have higher amyloid without symptoms, they decline faster in their symptoms over time. So there's a lot of stuff that says, look, if you have amyloid in the brain and you have a high amount, you decline faster in terms of some of these clinical ratings, or if you have a blood marker, p-tau 217, you decline faster, even if you have normal cognition. We study, I have a study where we're looking at healthy individuals and we're looking at different things like driving and other things that may identify sort of cognitive changes early on. And we're seeing some differences in perfectly normal people with and without amyloid in the brain. So you begin to see these early little changes, but the point of that is to be able to define things early so that you can see what happens when you treat. There was another group that doesn't like Clipper that was there. And a friend of mine is a member of this group, and like the first time they announced this framework, ATN, amyloid, tau, neuropathy, neuropathology framework, this person was behind me working on the question to show Clifford he was an idiot. And I could hear her going over and over again about, you got to think of clinical problems, you got to think of clinical problems. But, you know, the American version or the one group's version says, we do think of clinical problems, but the disease is driven by the biology. Does that make sense? So what happens though is the international group says, the international working group says, well, you know what? You know, we believe in pathology too, but we want to look at the needs of patients and we want to think about changing lifestyle and reducing risk. So we don't want to really concentrate so much on the biology of the disease. So you get guys arguing about something just sometimes just to argue, but nobody, you know, this is the staging, biomarkers, subjective mild cognitive problems, cognitive impairment, Alzheimer's disease, severe. These are the stages for clinical appearance of the disease. This is what the IWG is interested in is, I'm interested in risk. I agree with you here, but I don't want to break this up because everybody's different. And the IWG says we need to spend a lot more time on what the risk is of Alzheimer's before we start treating people. So it is a interesting problem because when you travel around like I do, you get people with very interesting ideas about when they want to treat them. Some want to treat people very early. Other people say, well, no, you know, until I see a problem, I don't want to give them a medication that could cause side effects or other things. I want to wait till they have problems. The difficulty with that is that too late. We just don't know yet. So, but it's amazing how much these guys will yell at each other. And they all go, well, we're friends, but underneath it, they get as competitors all get out. So now I'm going to talk about, because this is the big issue. This year, one of the biggest issues, again, was continuation of medication effects. And what are the latest medications? I'll talk about lecanemab first, because this is one that at AAIC, there were a number of papers and posters for both of these drugs. We have lecanemab and we have donanemab. We have 2 approved drugs in the US for doing it. And lecanemab is in Europe yet too, right? Aducanumab is not yet. All because of these different issues about who wants to treat when and where and why, and who wants to think about side effects. So the studies on lecanemab at AAIC basically said, hey, look, we were approved two years ago after a 2-year study. Now we're going to follow that study, and we see that people are continuing to have a slowing of the disease. These drugs affect amyloid. These drugs kick amyloid out of the brain, essentially. So that's a good thing. It can lead to some side effects, but that we'll talk about. But basically, it removes amyloid, and now we know we should be looking earlier and earlier, because that's probably when these things become a problem. So there was confirmation that lecanemab works over time. It seemed to have a good safety profile. There's people here who know both of these drugs much better than I, and they can tell me when I'm wrong. And also because I was up pretty late last night, as Stephanie knows, trying to put these slides together so they can tell me when I'm off. But long-term efficiency and management and safety, the longer somebody has the drug, the better. The earlier they get the drug, the better. There was also a real attempt for both of these drugs, especially with lecanemab, for looking at real-world effects, right? And we forget about how important that is. It took a long time to get Cinemet from the research lab into Parkinson's disease. Why? Because there's no clear pipelines, there's no easy way to do it. Doctors have different opinions about different drugs, and it's a real problem. So one of the most important things was to say, what about the people who are using this drug on a daily basis potentially? What do they have to say? What do their doctors have to say? Are doctors happy with how this is working? What about the pipelines? All these different things. There was a lot of discussion about that, demonstrating that these drugs can work in the real world if you get the proper organization to get it done. A lot of, as long as you adhere to the safety profiles, things do well. And for lecanemab, first, they have the first subcutaneous. So these drugs are significant medications. They're done with an IV. These are IV administered drugs because they have to go fast. Both companies, especially AAIC with lecanemab, are looking at other ways to distribute these drugs, because it's very hard to come to an infusion center every time you need to take this drug on whatever options you are and whether you've been taking it for a long time. What if people could do this on their own? What if your partner or your nurse in your senior center or your living center could do this for you, or you could do it? What if you could take this drug on your own? So there's a lot of interest in doing that. And these are the studies that are ongoing for Leqembi. I think I've got them all here. There's this long-term extension, which says we're going to follow these folks that started it when we did the original studies. Government requires you to present data from a 2-year study demonstrating that this drug has an effect and it's safe. Big deal. So we're going to follow these people out for 4 years. Another study, which is very interesting on preclinical AD, which is what if we give this to people that don't have significant behavioral findings yet, but they have amyloid in their brain, determined by blood or staining or whatever you want to do. What if you can, well, I mean, there's specifics for that for research, But what if you could give this so early that the amyloid is first getting into the brain? What effect would that have? So that was really important. They're also part of the DIAN-2 network, which is the network of individuals which families around the world who have a high genetic preference. They have presenilin genes. They have certain very rare genes that cause individuals to develop Alzheimer's around 5 years when they're picked from when they're parented, before or after. And these are individuals who develop it before age 60 or in their very early 60s. I've seen a patient who was 32 years old who had early onset Alzheimer's. But we know that those people, the other interesting thing about people in the DIAN study is that there is the disease process, that cascade I showed you, without a lot of other stuff going on. So without Huntington's disease or Parkinson's disease or severe cardiovascular disease, these are healthy individuals, but they have a high risk for this disease. So that they're doing that as part of that study. That study is able to study a number of different medications of the way it does it. And then, interestingly enough, lecanemab has another study starting that is looking at both, or has started. Is it? It's not closed yet. No, it's not closed. I don't know, but the interesting thing about this study is it's taking both a tau drug and an amyloid drug and combining them and saying, you know, if we give people an amyloid drug relatively early on and we try to affect tau, does that improve things even more? So there's a big interest. That's just an early study, but it's one of the first times people have been combining drugs. But the results for these studies are roughly similar, but what happens with Leqembi is they have 4 years, and what you see is now a lot of issues, and I'll talk about this in a minute about something else, but how do you treat people if you're pretty sure you have a drug that makes a difference? How do you run a study with placebo controls, and afterwards, after the study's done, and you tell people, well, I can't tell you what you had, thank you very much, goodbye. People don't do that, they restart the drug. But one of the things that this study showed, this is up to 4 years, is showing that these are 2 different studies in the US and Europe that have gone on to look at individuals and their normal age. These are healthy individuals. And we know there are some changes in NMCI patients, but we know there are changes over time as people develop Alzheimer's and mild cognitive impairment, but this split continues and it gets bigger. So that's part of the argument on the part of Leqembi that says, you know, our drug has a special action, maybe you should be taking it and keep taking it, even when the amyloid's gone, because we might be stopping it from appearing later.
Can you explain the units on the y-axis, like with the CDR-SB?
Oh, I'm sorry. Yep, CDR-SB is the clinical dementia rating scale. So this is what a clinician does when somebody comes into the office, and it has a bunch of different pieces. One of the issues is that all of this is also an attempt to say, if somebody comes in and we test them and then they come back the next day, they might test differently or other things. So what we want is somebody's opinion for what's going on. So we use this in consensus conferences to diagnose individuals. Everybody has to get together and agree with the diagnosis, but it includes memory question, a memory interview, attention, and you can do this with the patient and with the care partner. So it's a marker for what's going on. So people start out quite well and then begin to decline if they have disease. But, even if you have mild cognitive impairment and things and Alzheimer's disease, as these groups are, the Leqembi group is slow. So this is a hot topic. And the other thing, I'm not going to spend a lot of time on here because it's too many slides and too much discussion, but for both of these drugs, there is a side effect called ARIA. And people have said, look, you know, ARIA occurs as edema in the brain or bleeds in the brain or things that are rare, but they seem to occur at a higher rate with this drug, especially if you have certain genetic APOE, certain genetic combinations for your genetics, you may have a higher risk. But what this shows is as time passes, the number of events goes down, and we also know that people are paused. If you have one of these problems develops, this is why when somebody takes this drug, and both drugs, you have to have MRI changes to see what happened. Some people say, well, look, you know, somebody has amyloid in the brain, you're taking that all out. What's going to happen with all that extra space? So there's a lot of discussion about what could cause ARIA, but we know it does occur. So that's this is showing that they were able to show that as time passes, these events go down. The group here with the higher number of events over time, these are individuals who have homozygotes who have APOE4 genes. Have you guys, somebody talked about that, the genetic, APOE4 is a risk gene. It's a risk for Alzheimer's, it's a risk for a lot of things. But people who have this gene in its with all these sort of alleles, all the parts of the gene together, have a higher risk for problems like Alzheimer's and have a higher risk for ARIA, for side effects. So that's why if you know somebody who has problems that goes into the doctor, their physician to talk about, their clinician to talk about taking this drug, there's going to be a discussion about whether somebody has APOE4 genes. And there'll also be a discussion about, are there already some MRI changes we have to worry about? If you don't have those things, then there's probably much more of a chance that you'll make that decision to try the drug. So these are just more risk factors. And this is the auto injector. There's any, you know, there's Venus Williams, who was just on TV the other night, and who's the other Williams sister? Sorry. Okay. My wife is a much bigger chemist. But I just saw her on TV, and she has lost a phenomenal amount of weight, and she uses an auto injector, you know, and shows you on TV. See, I just do this myself. Because a lot of these new drugs that are coming out for weight are auto injected. So that's why this thing will make a big difference if it works. And there already were studies presented at AAIC that said doctors like this issue, patients like this issue, they can follow up and check and see how things are going. So this will be a significant change for how this drug is used, and it's really pretty cool. So basically, I mean, it makes a difference. It's easy to administer the drug. It's convenient. People were found to be confident. Oh yeah, I can use that because I've already seen other people using that. And people really like doing it. Much more so than coming into an infusion center, driving to a center or driving to the University of Michigan hospital and then trying to find parking and trying to come in to get drug. I'd like an auto injector too. You know, it's a fact. Now, donanemab, which was the second drug that was also approved by the US a little bit, has also continued to show stability over now 3 years. So that was important. It also continues to show a long-term benefit. Each of these drugs, the studies are not exactly comparable because nobody does anything in the same way. So people got into lecanemab a little differently than how they got into donanemab, but the results are basically the same. And there are multiple studies. There's Trailblazer 3. Again, this is the other study, the comparator study that says I'm gonna get rid of amyloid before people have trouble. And so I think stuff comes out in CCAT probably, or I don't know when this stuff will come out. But a lot of these studies will start to report out next year and the following year in terms of what the results are over the next couple of years. But Trailblazer is the same thing as AHEAD is. There's another study which is more of a global study looking especially in different parts of China. Can you take this drug effectively? There's Trailblazer 6, which looked at, hey, there's no real difference in how lecanemab is dosed, but donanemab can be dosed differently to lower ARIA problems, which were an issue initially. And then this whole long-term follow-up, the same thing. The Alzheimer's Association also has had a lot to do with this long-term follow-up because they want to get data demonstrating the effectiveness of these drugs over time. So again, there was this whole issue that just like I didn't show you in lecanemab, but a lot of people got rid of amyloid very quickly with this drug. A little bit fast and about the same rate actually as lecanemab, but this drug stops when the recommendation is to stop this drug when the amyloid is gone. So it's a different approach to how the drugs are dosed. So you don't go on sort of a longer term retention use. Yes.
I don't know if there are phase 2 or phase 3 studies, but you know,
Three.
inclusion criteria study.
Yes, there are noteworthy exclusion studies for these studies related to brain changes, age, I mean, there's all sorts of exclusion. That's why the real world studies or the follow-up studies I didn't show you that are going on over here, I'll show you here. That's why these long-term studies make such a difference. And both of these drugs are very effective at getting rid of amyloid. There are some differences that you need to think about in terms of how you look, whether you have amyloid in tau or not, or things like that. But all these drugs are showing a gigantic effect on getting rid of amyloid. Both of them look very similar. And when you put people who are on placebo on the drug, they drop too. So these are long-term over 154 weeks. Divide that by whatever, and you get a number of years, it's like 3 years, whatever. But yes.
So regardless of history, you're still seeing that same.
Yep.
Slope.
And that's why these real world studies are really important. It's great when you go into sorry, I'll babble for a minute. It's great when you go in, and Stephanie's not yelling at me yet. So it's great when you go in to do a study. And look, I have a list of 12 people in my study that I have to call back, and I'm calling them back to say, really hard to get a hold of people, but my research assistants are really busy now, so I'm trying to do the calls. But it's really hard to get somebody to call you back, because they're busy, or they're not home, or they screen their calls, and who's this weird guy calling? But all of that stuff is so specific in a research study. When you get to the real world, what happens when doctors start giving out this drug? That's why, like the real world studies with lecanemab, where there was a lot of discussion, were really interesting because they were saying, look, you can give this drug, it really doesn't cause any more side effects, and we can be a little more open with how we deliver this drug. So that's why these things are important. Studies are maddening to people because they say, and I got yelled at by one guy, which is really mad. I spent all this time in your study doing a PET scan and all this other stuff, and now you don't want me. I'm trying to explain, well, all the little boxes are getting filled full of people. The study's ending. But anyway, yes, sorry.
Can I ask 2 questions?
Yeah.
I'm sorry.
I love talking.
What degree of correlation do we have between the burden of amyloid in the brain and what the actual cognitive is?
That's an interesting question because when you have, oh yeah, I'm sorry. The other one was, is it hard to get into a study, and what happens when you're not in the study? Is it what are the side problems? this was a question of, is there a relationship between cognitive changes and amyloid in the brain? Remember, I said that amyloid loads for 10, 15, 20 years before you have problems. That's why there's big. So we have a study going on here in Detroit where we looked at EEG changes in healthy individuals who don't have any problems. Some have amyloid in the brain, some don't. And we do all sorts of deep machine learning stuff that, I mean, I try to understand it, but my engineering friends are talking 300 miles an hour and they just throw up equations like it's nothing. But that shows differences between people with and without amyloid. I can tell you that I'm seeing some differences, interestingly enough, with more complex driving accidents. And I don't know why that is, that's what we're trying to understand. But these things seem to be before you see cognitive change in the head. So everybody's trying to find what could be the latest thing to tell us. Because the earlier you can go, the earlier you can die. And frankly, you don't want to go on a PET scan. We'll talk to another thing about, I mean, you don't want to go just because it's expensive. I don't want you to go on a PET scanner because it costs me $5,000 to get a scan done. But that's why we're looking at all sorts of other ways to do that. But during that period when amyloid is loading, it's very hard to see a lot of differences. But once tau gets into the job, there's a very strong correlation between tau level and cognitive impairment. Makes sense because tau is happening as the cells begin to fall apart. Yeah. Oh, sorry.
I am in your study when I get both PET scans. So would you tell me that I have amyloid in there so I can do some early intervention?
Yes. I mean, there are studies that do that. We have studies, one of the problems because we're in research, right?
Right.
And you can't just tell everybody, hi, you have this or you have that, especially because having amyloid in the brain may make no difference and you may pass away perfectly fine. But without significant impairment, it's a real question. So there's a lot of concern with how to divulge this information. When I was doing studies back when I was 12, 15, 14 years old, we would tell people nothing. And that's not very fair either, right? But you have to sign a form that says, I don't want to know what's going on. Those days are changed. People say that's not right. But there's a separate study on that does that. You can call the number and ask to be in the set. There's a separate study going on that then gives people information and talks to them about what it means. Because if you have MRI changes and amyloid and tau in the brain, that means something different than amyloid. Now, the other thing about these real world studies that's interesting is, and see, I'm getting off topic, but there's another thing that's really interesting is what happens when somebody comes into their doctor's office and says, I'm worried, I think I have a memory problem. And the doctor kind of talks to them. There's nobody in their family that had memory problems. They're 45 years old. They're trying to learn a new computer program at work that's really hard. I mean, there are a lot of reasons. They have no apparent amyloid or tau in the brain. Now we might do blood studies as a screen and things, but that person is treated differently than somebody who comes in, has clear memory problems. Not very significant, but on a PET scan or on CSF, on little poke in the back, there may be a lot of amyloid and tau, or there's very little tau and a lot of, very little amyloid and a lot of tau, the CSF, because the amyloid is up there clumping and the tau's up there clumping down. So all of these things are important questions because there are side effects to these drugs. And why do you put, say, a 45-year-old person who has a worry into one of these studies? That person probably is much better off, and that's what the IWG would say, is I'm going to take people who come in without a lot of strong problems and put them into life cycle. And then Clifford says, Yeah, but if there's some amyloid in there, I think I'm gonna treat. So those are the two differences in those groups, because the IWG group, the European group says, I don't wanna treat until I see problems. Clifford's saying, and some other people are going, I don't know about that. The Alzheimer's Association is saying the same thing. You have the biology that makes up the disease. And nobody has been able to say, if you have amyloid and you have tau, then you're not going to get that disease. If you only have amyloid, there's a question. But once tau appears, cells begin to die, and you get that ATN framework that Mark was on. So that's why there's a lot of difference. Yes.
What I don't understand is I have a relative where they went to a neurologist. I thought neurologists would have answers and they misdiagnosed. And
Yeah.
they said it was depression and they took the relative off of the medication.
Right.
And then we saw a rapid
Drop, because if you come off of that med, you drop. But yes, that's true.
So I'm like, how can a neurologist misdiagnose? I thought
It's not, it's not always misdiagnosed. It's trying to have some security about the diagnosis, or to say, I think other things are going on. But you also have to make that diagnosis or make that change in medication, knowing the effects and knowing what's involved. And it's really hard to do that. That's why these real world studies are going on saying, like, look, one of the first things we need to do is we need to teach people. So one of the things the Alzheimer's Association has is it's developed this whole ALZ.org network, something, a whole sequence of trainings for physicians and clinicians and nurses on what is Alzheimer's, what are the effects, how you can measure amyloid, when you should measure these things and all, because it takes a lot of training. Because like I told you, I think getting Cinnamon to Parkinson's disease was like a 15 or 20 year event. This is much faster. These drugs just got developed.
but a specialist, I mean, and to see, so you're not surprised that once the medication was stopped, it was a rapid decline? You're not
We do
surprised?
know that when you stop these medications, these anti-amyloid drugs, there is a faster decline from where they were. They would have been, excuse me. And it's a much faster way to get there. And that's something we don't understand. Look, here's the other problem. If somebody is in a nursing home with significant memory problems already and significant problems and eating problems and other things, do you stop one of those drugs? These are decisions made individually. People have to make these decisions, but you need to involve the patient and you need to involve the family to look at the risks. I had a patient once who was diagnosed with depression that I can still remember that they had been treated for depression for like 10 years, and finally two of the physicians in that person's office came to me and said, look, we've been covering for this person for the past 3 years. We're not going to do it any longer. You need to do something. Nobody had seen this change. It also depends on how are you doing the evaluation to see if somebody has a problem, right? Because look, my mother was really having problems. I mean, my mother, the Italian chef, I opened the cabinet one day and there was bottles of ragu. I mean, just bottles of ragu everywhere. And she goes, oh, I found if I start with this, it's much easier. I throw in some sausage. Your father doesn't even notice. Why? Because she couldn't follow directions. She called the police and said that my daughter was stealing money from her and when the police got there, luckily my father called me and said, I think you better come because there's something weird going on. My mother pointed to the back of her checkbook. This was the old days. Any of you younger than me don't know what a check is. But in the back of her checkbook were all these torn checks because she was writing them, realizing she was doing them wrong and tearing them up. But she knew she could never have done that. It must have been my daughter, who she was totally linked. Well, while all this was going on, this is a problem. I saw her every day. I didn't see that. But once these couple of events occurred, I knew, okay, we got big trouble here. I took her to her geriatrician, who is skilled, was famous in Ann Arbor and everything. And he says, how dare you suggest your mother has problems? My mother also sat next to a chairman of neurology at a reception who thought she was the most amazing, brilliant person in the world. Because they never heard the confusion, they never saw the confusion, they never even noticed the repetitive questions because everybody's talking and it's a dinner. So a lot of it depends upon how you diagnose. But this person would not diagnose my mother until I said, I'm going to sit there and do it in front of you. He said, okay, I'll give her 3 questions off of the 20-question test, and that'll be all that I'll cut. And then he came back out and said, I'm sorry. I should have done this a long time ago. But my mother was an attorney. She was smart. She don't ask me questions, Yes.
Now I have another question, but I
Yep.
made them short in my mind. So,
Okay, but I make them much longer. So.
so lecanemab in the Clarity study, there were, now one of the adverse outcomes was intracranial hemorrhage.
Yes.
Was that in the people
ARIA.
who had ARIA E or the other type of ARIA, or is one of those types just an imaging finding that doesn't translate to clinical issues?
They are usually both types.
Excuse me.
Oh, okay, sorry. Stephanie's looking at her phone. Stephanie's not doing her job, folks. It was a question about ARIA, these side effects that occur when somebody's on one of these 2 anti-amyloid clustering drugs. Those side effects can be at different levels. And so you have to make a decision on taking somebody off the drug. But once they go off the drug, it's sort of like a holiday and come back. Those problems usually don't occur. There are very few, both of meds, very few serious.
Okay.
Very.
And then second question, can you skip?
I did okay, that was only 6 seconds.
That was great.
Yeah.
Can you skip a tau PET scan if you have a positive amyloid and atrophy on an MRI in the same regions of the brain? Can you just invoke that there is tau because there is atrophy where there's amyloid?
Well, there are certain types of amyloid diseases that are amyloid.
Yes.
Or, I gotta hire you. Although Stephanie was looking upset. The question was, what if you have amyloid in the brain? And you've already paid all this money or I've already paid all this money for a PET scan for you, for my research. Can I skip the tau scan and just look at the MRI that shows atrophy? The answer to that is no, because there are some diseases that are amyloid only, that are amyloidous. There's no tau. There are other diseases that are tau only. Boxers, dementia, football, CTE. These kind of problems are tau only because of these repetitive hits to the brain that appear to cause tau to come out of cells and things because of these repeated hits. But there isn't amyloid. They don't get treated the same way. So, but anyway, both of these drugs get rid of amyloid. I could show you the same picture basically for both drugs. And again, for this drug, it was sort of mixed, but they're basically showing again that if you compare this to these ADNI individuals, these individuals in this other study who were just followed over time, again, the donanemab shows the difference. It slows. It's not this. This would be a cure, right? If we went this way. This would be arresting disease progression, but disease keeps going down. That you figure you get with these drugs 14, 15, 16, 17, 18 months. But the real world data is suggesting it may be much longer before somebody goes on a noticeable, has noticeable changes. And especially as they track amyloid. So both of these drugs are doing well. Again, what this donanemab is saying, well, when somebody has basically no amyloid, we stop the drug, and over weeks and weeks and weeks, we see an increase in amyloid about what we would expect in normal to happen. So the donanemab is saying we could stop the drug. Lecanemab says we don't recommend that because there could be amyloid forming. So this is how you make intelligent decisions with your physician about which drug you want to take based on what your standards are. But the other thing here is the ARIA risk really appeared. And I'm sorry, let me move on. I have so many slides.
5 minutes for talk and then question.
Okay, maybe 7 minutes,
Sure.
because I just added 2 minutes right there. Okay, so I want to show you a little bit of very interesting information. So one thing, why don't these things cure people? Why do we have to give people so much drug that ARIA could occur, that side effects could occur? One of the problems is this thing in our brain that's incredibly important called the blood-brain barrier. This is why people worry about head injury, because if your head injury is severe enough, your blood-brain barrier breaks down and stuff gets in there. Well, there are other disorders that happen. So there's a lot of interest in the blood-brain barrier because basically, I think it's only something like 3 to 10% of drug actually gets through. And then you don't know where in the brain exactly it's getting. So this is a big problem. So there's a lot of interest in different things you can do. This is, this is an interesting one that's been around for a long time. That originally was done. It's opening the blood-brain barrier with acoustic sound. So, and there's research on that here in the Detroit area too. We give people these little bubbles that burst and compress and expand and compress with sound, and that causes the blood-brain barrier to open. The first interest in this was maybe if we open the blood-brain barrier, good things will go in, bad things will go out. But now it's a potential way of getting drug into the brain this way. But it it's not a simple thing to do. You have to monitor the person. You can't leave it open too long. There's all sorts of potential problems. It needs to be done somewhere where people really know what they're doing. But there's a lot of interest in this. Sort of get these little cells to bubble open, bubble close, and it seems to open the blood-brain barrier. There's another set of studies that were talked about with the gut. That there's you get this vagal nerve here that goes from the gut all the way to the brain. There's a way to go from the stomach to the brain. And some people are suggesting maybe we can put drug in there because that nerve goes through the microtubules and very small blood vessels and goes around the blood-brain barrier. But that's a long time in coming. But there's another thing that I thought was really cute. Last year it had one talk, I think only last year. Now it had a session, but frontinamab, which is a brain shuttle. So what this does is it essentially takes a drug, in this case, gantenerumab, which originally was in the Diane studies and didn't show an effect. But this particular company is very strongly wedded to the results of that drug. And they felt like it was because it wasn't getting into the blood-brain barrier. So you essentially give it to this camouflage drug. It goes to the blood-brain barrier and shuttles over, and then you can get these drugs. And then you have to only give a much smaller amount of the drug, and a lot more gets into the brain. So this is a lot of interest in this technique. I think is going to generate a lot of interest because if we could get more of either of these two drugs we have now in the brain without giving such high levels, and they've already shown that the trontinemab basically leads to apparently less ARIA and faster changes, but that sort of shuttle thing is still very early. They're doing phase 3 now. Then there's a whole range of other drugs with names I can't explain, nor names that I know sort of make sense, but then again, I'm not so sure. And my sister-in-law, who's been doing this stuff for a long time, it's because it's a monoclonal antibody, or that's because it's a gut drug. But anyway, and then I point out that no, there's a monoclonal antibody that ends in TUG and one that ends in PIP, whatever. But there are a number of other drugs with different effects being studied. So there's a lot of stuff going on. And these were just the ones that I counted clearly that had sessions about their early effects, but this is the actual number of drugs being studied.
Wow.
Yeah, wow is right. These are phase 1s, phase 2s, and phase 3s. Phase 1s are basically, hi, come here, young person. I'm going to give you this and see what happens. So, you know, and a lot of that is also done by computer now, I think, so we have a lot of data. Phase 2s are, I'm going to give this to people with the disease and see how much I have to give and how that works. And phase 3s are the things that lecanemab and donanemab have already done to show the government that these studies work, that these drugs work. And these are much more involved studies involving thousands of people across 2 years, 3 years, whatever you do, usually 2 years. So there's a lot still happening. And a lot of these things, you can't read this, but these are all the things doing. These are the number of amyloid drugs going on. These are the number of tau studies going on. So far, tau's had a lot of trouble, and that one drug from Huffman LaRoche is there. There's a lot of interest in inflammation, a lot of interest in trying to affect these neurotransmitters that cause amyloid to develop. There's just a whole bunch of science going on if it gets money to continue, but a lot of this has been knocked off too because it's animal studies. So real quickly, a couple of other things. The big interest here, and now I've only put 2 slides in for it, is the US pointer study. Around the world, there have been studies going on, and this is there are differences between Europe and the US, right? We already saw that intensity. I mean, there are plenty of people that take the IWG outlook in the US, but basically there's a difference in diagnostic patterns. There are differences in treatment. People trying to stop the disease development in Europe for years have been studying, let's put a whole bunch of things together and see if it works. In the US, we tend to say, okay, I'm going to give people one thing, I'm going to challenge their memory to be better, and then I'm going to see what happens. In Europe, people go, let's study memory, attention, let's give people the right foods to eat, let's take them to the doctor, let's do all this stuff and see if that works, then we can go back. The Mediterranean diet, you guys know the Mediterranean diet, and then the salt diet, and then whatever the other one's called from the Alzheimer's Association, I can't remember now. Sorry if you ever see this about Alzheimer's Association, but anyway, you can't reproduce that effect. People have tried like crazy to break it into parts and pieces. Why the heck does the Mediterranean diet work? Oh, I'm going to give you a lot of fish oil, or oh, I'm going to have you drink a whole lot of red wine from Sardinia. That one's good, but those things don't work on their own individually, but together they seem to have a chance to work. So in Finland, they did a study called the finger study, where what they did is they had 4 components. They helped people's health. They had people exercise more. They improved their cognition. They had them socialize more. They did all these different components, and they did diet, exercise, cognitive engagement, and health monitoring. They did those 4 things in Finland, and the study stopped after 2 years because it was having this amazing effect. That showing that was really reducing cognitive problems that people develop later in life. So there are finger studies all around the world. There's the finger study in China. There's one in East Asia. There are finger studies now going on. Each of them interesting because each of them responds in that particular country's interest, right? But in America, they didn't want to call it the finger study. It's a fire. There was a long story involved in that. But they weren't going to call it the finger study, they called it the pointer study. And what did we do here that related to our way of life? What we did is we didn't change people. Now in China, they're doing all sorts of dietary changes and things. We developed a study that compared structure to self-guiding. Because in this country, we do things on our own. We don't want to listen to anybody, or we do listen to people. So there were 2 different aspects. So the structured aspect went through these things very carefully. Then COVID hit, because we were behind in the start of this stuff. COVID hit, things slowed down, but they've kept amazingly going through Zoom and everything else. But 2,000 people did this study. They were specifically sort of all comers. There weren't a lot of ways that you got knocked out of the study. We were talking before about getting knocked out of the study. And the main difference here is everybody improved. But the structured group started improving more than the self-guided. So over the time of this 2-year study, you could see a definite difference. Now, we're back to the same problem with drug studies, right? Because if I have a drug that I know stops amyloid, how, I can't keep giving people placebo. They felt there's so much evidence around the world that changing people's lifestyle makes a difference. We're not going to have a placebo. But, so this has yet to be seen how this compares, and they're beginning to do those comparisons now to those existing studies. Yeah.
Would it be fair to say that the drug companies are very interested in lifestyle interventions because they can't make any money on it?
No, because they're really interested in lifestyle interventions because they can't produce enough drug and they can't give it to enough people fast enough, and they want to give it to the right people. So that if you're somebody whose lifestyle is working and you don't have yet a lot of problems, that's great for everyone. So no, drug companies are involved. They're contributing. So it's really a good thing, not a bad thing. So very quickly, there's a lot of stuff in blood-based biomarkers. I don't have a lot of time to go into it, but we know that there are now different markers for different things. And these are what now finally, hopefully, once we get these things approved, that they can be used instead of expensive PET scans. And I don't know if I took out the slide, but I took out the slide. They're already one of these p-tau 217, this drug right here, which tells us a little bit about tau and about amyloid. This has already been approved. One company's already been approved to do this study. So FDA has already said, okay, I believe these results. And the reason is, I'll show you the reason for that, is because of this, clinical practice guidelines. So the Alzheimer's Association for the past couple of years has been working on this because what they did is they looked out at these blood-brain marker things, blood-based biomarker stuff, and it's like the Wild West. Everybody's saying they've got a better blood study than anybody else. But think about it. When I'm in Africa now, I don't need to take people. I don't need to find an MRI scan or a PET scanner, which they don't have. I can do all this by blood, and that's what I'm doing. So these, I'm sorry. Stephanie's not even yes, but keep going. So the Alzheimer's Association spent a lot of time, and it's ALZ Pro. That's the website that talks about helps physicians make decisions on when they can use blood-based biomarkers and what they can use them for. So a blood-based biomarker that's 90% sensitive, so it tells you the true positives, and 75% specific, sensitivity versus specificity, it tells you the true negatives, those things, then you can use that as a triage to look about those problems. But a test that's 90% sensitive and specific, so 9 out of 10 times it's right, and we have one of those drug tests now that's being studied, then it can be approved as biomarker. And that's going to be a and so I left that slide in. So this is Lumipulse. This is kind of neat. It takes both amyloid and tau, compares them, because we know that as you get this disease, you've got a lot of tau falling out of the brain and much less amyloid. So it compares the ratios of tau in the blood with and without brain tau, and compares amyloid in the blood, a percentage of amyloid in the blood. And this marker is already shown to be 92% sensitive and 97% specific. This will change everything, and it's like drug, donanemab and lecanemab. Once you get one, you get more. And so Lilly is already working on a new drug that would replace donanemab, for example. There are all sorts of new things going on, but once you get one marker, everybody else will figure out how they did it. And there'll be markers everywhere. This is the Lancet Commission I mentioned to you. One of the big changes in the Lancet Commission says, this is part of the IWG, says, we look at age and early life, middle age, late life, different things cause stressors at different times of life to tell us when we should what the risks are. But one of the things they did is now they've looked across the world. They've actually not just looked in Europe, and they said, whoa, wait a minute. Even in a country like Australia, we can go to 4 different parts of Australia and see different risks. So that's another reason why drug companies are not as worried about this, is because risk also appears to be dependent upon your genetics, all sorts of other things. So it's even these risk things are much more complicated to do now. But another set of studies this year, as in last year, that said basically don't hang around areas with a lot of environmental lead. So now I go back thinking about all the lead I pumped into my little Honda Civic, and I'm kind of worried. But you know, amount of lead exposure makes a difference. Amount of exposure of toxins that come out of fires, forest fires, is an even more probably serious thing, because those are even smaller parts. So all of these things make a difference in the contribution of stuff. A lot of interest in the SNAP program, which is the Supplemental Nutrition Assistance Program. They showed that people who actually took advantage of the government SNAP program, they did better. They showed there were some differences by race and age and things, but individuals that took this tended to have cognitive problems if they use SNAP and vegetables, whatever, tended to do better. So food insecurity is something. Walking makes a difference. But this one is interesting. So to tell you real quickly, this is why it's such a mess understanding these things. And that's why it takes a lot of study. Walking is good for everybody. And everybody says to walk. But it turns out if you have ApoE4, if you have that risk gene, walking is really good for you. We already know that if you have the risk gene, you're at a higher risk of getting ARIA if you take one of the medications. But here's a place where if you have the ApoE gene, the alleles for ApoE, it's actually a better thing to do it. So let's see. Where are we? Okay. The real results I talked to you about already. A lot of this concern about, main thing, would it be acceptable and safe to give these drugs in the community? And the answer was yes. A lot of differences, back to these differences in men and women. Traumatic brain injuries appear to have more of an effect in women than men. Not clear why. All we know is we see this, now we need to understand why. Chemotherapy, some of the same effects. Another study that was just done that again said, if you go to your physician, if you take medications for your heart, for diabetes, or whatever, if you take these combinations of medications, they slow your risk of problems. And we know that because cardiovascular disease is a significant, untreated cardiovascular disease is a significant risk factor for Alzheimer's. This is my problem in Africa, where we're looking at HIV, and I try to tell people live now into their 60s, 70s, and 80s with HIV, but HIV has associated with it cardiovascular disease, as well as diabetes. They're coming on as a significant risk for Alzheimer's disease among individuals with untreated HIV, especially not treated. But the problem is, what do you do? Because you can't get an HIV doctor there to look at cardiovascular problems. They're already so busy, they don't do it. So it's hard to do that type of education. Then I just put this slide in because of the vagal nerve, but basically, darn it, there is a way that stuff comes from the gut and affects the brain. I'll just put it that way. And I can't get rid of them. I know I have a friend who studies gut like crazy, and the study we're doing in Africa, a lot of it really is measuring gut factors that affect the brain, but I can't stand it that it works. And you know that this person's been right all this time who says the gut runs the brain now. You know, and they're right. So thank you. I mean, yeah. It's 10 minutes.
I just have one.
Oh, you have this
on
one.
the diet.
Yeah.
That S is something, where you, for weight loss that people are taking.
Oh, the drugs. Yeah. Oh,
Some it said
said-
had an effect,
Yes.
and I didn't quite
I ran
understand
through
that.
that slide really quickly. GLP. These drugs appear to affect inflammation. And we know that one of the things that triggers tau and triggers this kind of effect between amyloid and tau. Oh, what was that was asking? Look, I remember. So good. She's writing, so she missed it. But the question was, what about these GLP drugs, these new memory loss drugs? What I'm just repeating the question. So, but what about those drugs? And why is it that people are interested in those? Because besides losing weight, and we know that significant weight problems are a problem as well because it leads to diabetes and other things. But those drugs themselves reduce inflammation. And there's been this thing that has never gone away that people say, you know, you got to look at inflammation. Some people don't want to, but you got to. So something happens in the brain with inflammation that triggers all these changes, and it may be a trigger point. It's possible that that's why people are beginning to see things with those drugs. But it's a long way from being studied, but they're beginning to study it directly. Yeah.
Peter, you talked about oxidative stress in there. Yeah, like mitochondria.
Yep.
That all kind of goes there.
Don't stress. I try to tell that to my dog, but he wants to go out all the time. Any other questions? Yes.
You had someone that was young as 32 that you saw early onset Alzheimer's, and it starts in the brain a year before.
This individual turned out to have been adopted. And a number of people, and you know, that just triggered a whole search and everything because they carried a gene that was specific to a set of genes that are specific to Alzheimer's. And when he came in, he worked in public utilities and had backed the truck through the back of the garage. And people noticed that. But then again, he drove to Florida, there in back like the family had done for 25 years. So, you know, he had ridden in the car with his parents, he had driven his wife, driven his kids down to Florida, but he had done that same thing every single time. And he was beginning to make mistakes, and you know, getting a PET scan and it was pretty clear. So you just don't know. But it caused a whole triggering search for family. Okay, any other questions? Yes.
Much earlier, mentioned there's a large number of people with Brown Alzheimer's or dementia.
Yeah.
Yep. So if they haven't been diagnosed, how do we know that there's X number of people who have it that they have?
In population studies, we see that. I will tell you about here in Detroit. So here in Detroit, we have a study where we ask people, do you think you had a change in your cognition or your memory? And somebody might have done that in here as an EEG study. But we asked people if they just thought over the past year or two if you had a change, and then we were doing EEGs and we were testing, half of those individuals had mild cognitive impairment. That had never been diagnosed. Because if you're living alone or even if you're living with a spouse, people don't often notice those problems. You know, it's one of the difficulties that occurs. Yes.
Increase in Chinese.
Oh, right. No, the issue with China is China's very complicated because we don't do that research anymore. You know, they cut off those fundings, but also because China's plenty wealthy to do it something. But the issue there is it has a much faster aging population. So people are getting older they have You know what? It's my fault. It's the baby boomers, right? There were a lot more baby boomers in China. Bigger population, more people are getting into their 80s, more people are having dementia. That's not a system that knows how to deal with.
So it's not
It's probably not something about China.
that they have better diet, et cetera, et cetera.
That's why they're so desperately doing these studies about better diet. It's true, like, look, and also for them, it's what do I do with individuals? Like in Italy, we brought my father when he was 96 to Italy because he wanted to see year 95, whatever it was. He wanted to see Italy one last time.
Yeah.
Not a great thing to do with your daughter. I needed my wife. We needed 3 people at least because he would, he was in a wheelchair, but he'd still wander off, or he'd still wake up at night, things like that, because he had the beginnings of a dementia. This was cardiovascular related. It wasn't Alzheimer's disease like my mother. But the problem is, there's no help in Italy. There's nobody to come to your house like there is here. Home care. There's no structured centers for memory care and things. They don't have retirement. You stay with your family or you stay in your little house. So it's partially that problem. So China's first thought in some of this from the people I talked to from a couple of the areas was, okay, we'll build a big giant building and put everybody in. Well, they're never going to come out of their room. Plus, you can't have all these people in there. You got to check on them and things like that. So now they're trying to develop a wholesale thing, but it's more their general worry. But there still is a lot of interest in are there differences in genetics. For Alzheimer's disease in Africa, there's a lot of interest because ApoE gene and some other basic genes aren't the same. Because people in Africa have been around longer than people in the West. So the genes have mutated. So it's all these things become really fascinating factors and make a mess when you're trying to give out medication. Okay? Stephanie, it's
take the time to fill out the evaluation form, we would greatly appreciate it. You can just drop it up on the desk with yellow.
Are there evaluation forms?
Yeah.
I usually bring in chocolate.
So you have sandwiches, and water.
Thanks, folks.
Thank you.
You probably or just get. I'm actually here. My mom was just that's okay. And her father had some. I don't worry. I saw my sister. We're just meeting with her. She was suffering from that. She had been analyzed they said, hey, thing she has. The guy